Right, good afternoon everybody, and a very warm welcome to you all. I'm Janice Goldstraw-White. I'm one of Martin Gill's colleagues at Perpetuity, and I'll be chairing today's session. And today, I believe, is our 189th Thought Leadership webinar, and today's topic, as you know, is tackling healthcare fraud. Is it the uncontrollable beast or an example of good practice? As many of you already know, we're here every week, usually on a Thursday afternoon, and we examine a topic of central interest to the prevention of crime. And the idea of these thought leadership webinars is that we critique today in order to get a better idea the type of prevention to put in place for tomorrow. And it's not really our intention ever or today to solve all the world's problems in one session, rather to encourage new thinking and new ideas, to debate what's going on, and to put forward different perspectives to change current practices. When we've actually completed the webinar, there'll be a copy with the video on our website tomorrow that can be referred to in the future. And if there's any past webinars that you're interested in, you obviously can see those there too. Okay, healthcare fraud. Well, we know it's a massive problem, and the scale is only sort of best guess. We've had some estimates from the US, where the FBI say it costs tens of billions of dollars. In the UK, in England alone, we certainly know that the NHS is vulnerable to at least over £1 billion worth of fraud every year. And when we talk about the word fraud, as we do for every sector, it includes a wide range of criminal acts, and it varies greatly. And it could involve staff for the NHS, for healthcare, it could involve doctors, general practitioners, and other professionals. It could include contractors and even patients. But the outcome to me is always the same. The losers are us, the public, either through depleted public funds, meaning we can't get treatment, or in increasing insurance or other premiums for those healthcare services in other countries that operate different, less public systems. Meanwhile, the state sector resources, therefore, around the world are limited, and as a burgeoning private sector is often marginalised. So what can we do about this? What we want to look at today is the key challenges. How are they being approached? What's the role of the private sector in being appropriately engaged for the public good? So hopefully at the end of this webinar, we'll have a look at the threats posed by the different dimensions of healthcare fraud, the vulnerabilities and how they're being responded to, and the opportunities maybe for the private sector to work with the public sector to maximise the overall public benefit. So today I'm very excited that we're going to hear from three experts in this area who all have immense experience in dealing with healthcare fraud. We've got two from the UK and one member from the USA. And therefore, we're looking forward to hearing what their thoughts are on this topic. So without further ado, I'm going to hand over to them in a moment and get them to introduce themselves and then make their opening statements. As we know, this is just a few minutes of what they want to say on this particular topic. And then after that, we're going to open it over to you, the audience, to ask questions. Therefore, can I encourage you to use your question and answer button on your screens? Please try and get your questions in early, and I'll endeavour to cover as many possible as I can in our ensuing discussions. So without any further delay then, let's go and meet our panel. Let's first go to Alex. Alex, please, can you introduce yourself?
Yeah, hi Janice, and thank you very much for the invitation to join the webinar. So I am the Chief Executive of the National Health Services Counter-Fraud Authority in England, and we are an arm's length body funded by the Department of Health in the UK, and our responsibility is to lead and coordinate the response to fraud, bribery and corruption in the National Health Service. So just a bit of context, about £212 billion was spent last year on health in England. That makes up over 40% of the government's budget for government departments. The NHS is the fifth largest employer in the world, I believe. I think we've got about 1.7 million employees. So there is a fraud risk, like it or not. It was the NHS's 75th birthday yesterday, wasn't it? 7th birthday, and it's packed to the gunnels with people doing an incredible job every single day. But sadly, you're right, there is a fraud risk in an organisation of that size. It's not all generated from within. There are external risks as well, and that's why we exist. So there you go, Janice. I've been doing the job since November 21, so reasonably new to this function, but spent a lot of time working in law enforcement in the fraud space prior to coming into this role.
Okay, thanks a lot, Alex, and we'll look forward to your opening statement in a moment. But in the meantime, can we go over to the US and we'll speak to Louis. Louis, please introduce yourself.
Hi, thanks for having me today. My name is Lou Sicoccio. I'm the CEO of the National Healthcare Anti-Fraud Association. And that's a not-for-profit organization that was formed back in 1985. And the concept behind the organization was to bring all of the payers together in the United States to basically share information and to support one another in the fight against healthcare fraud. So in the United States, because of the vast number of payers that we have, our members consist of 90 health insurance companies, plus over 200 federal and state law enforcement and regulatory agencies. The concept was to bring the private and public sides together to basically share information about healthcare fraud, do education and training, that kind of thing. So we're not a government entity, but we do bring all of those payers together. And because of the complexity of the healthcare payment system in the United States, it's critically important to be able to do that. I've been in this job since 2005. I'm an attorney by training. Prior to this, I was general counsel for the trade association that represents the health insurance industry in the United States. So that's a brief overview.
Okay, thanks a lot, Louis. It'd be interesting to compare the UK experience with the US experience and see if there's anything we can actually learn from that as well. Okay, over to you now, Nicole, if you can introduce yourself, please.
Thanks, Janice. Good afternoon, everybody. I'm Nicole McLaughlin. I'm the local counter-fraud specialist for Guy's and St Thomas's Hospital, which is one of the largest NHS trusts in the country. We have approximately 25,000 members of staff. We also provide a service for South London and Maudsley NHS Trust, which is a mental health trust based in the southeast, and we also cover Hillingdon hospitals. So I've worked for Guy's for about 4 years. Prior to that, I worked in the private sector, delivering a counter-fraud function to NHS organisations from a private perspective. And prior to that, I worked in the NHS Counter-Fraud Authority that Alex is the CEO of, and I started work with them around 2000. So pretty much when it started, and I worked there as an investigator and latterly as an operational fraud manager. And prior to that, just like most investigators in England, we all start in the council. We're doing benefit fraud. So I worked in Lambeth Council, and really baptism of fire, I think we can say, investigating benefit fraud in a busy London borough.
Okay, thank you. And we look forward to coming back to you and hearing more what actually goes on on the ground in terms of healthcare fraud. Right, I'm going to just remind you to get your questions into me, and then I will include those after we've heard our opening statements. So we're going to go in the same order again now. So the first opening statement we're going to hear is from Alex. Alex, can we please have your opening statement?
Yeah, thanks, Janice. So I think your question was, is it an uncontrollable beast or an example of good practice? I heard a football manager on the radio in response to a question. So I'm not going to sit on a fence, but I think the answer is both. And I think in this case, I'll be even more indecisive because I think the answer is both and neither. But let me take each point in turn. Is fraud uncontrollable? I mean, you hear people talking about a tsunami of fraud. 41% of crime against all individuals in the UK is fraud. That means that you're more likely to be the victim of fraud than any other crime. And that percentage is going up and up every year. We get a better understanding of fraud when that happens, but also the threat surface is increasing. I think particularly technology is acting as an enabler for business, but it's also acting as an enabler for fraud. But the reality for me is that in almost every case, I think that fraud is a choice. Now, it might not always be the choice of a victim, although I think that education has a big role to play there, but it is the choice of governments, and it's the choice of regulators, policymakers, even business owners and decision makers within those businesses. And the reason for that is that we can choose how tolerant we want to be of fraud. We can choose the control measures that we put in place. We can choose the speed at which decisions are required. And actually, we can choose to have a culture which doesn't put fraud in a cupboard of uncomfortable truths, which is a phrase we hear a lot in the UK. So, second point, is healthcare fraud a shining star of excellence in the way that we respond? Well, in terms of the public sector response in the UK, could it be better? Absolutely. But I do think that we've got one of the more mature functions in government. We have a function, for starters. So Department of Work and Pensions, Revenue Customs, for example, have always invested in fraud functions because they deal with money. But what we've seen in government is, as we've, particularly with Brexit, taken on more things like grants to be issued, but also pandemic, cost of living crisis payments, government departments have begun to realise that the fraud response is inadequate. But actually, I think in health, we've had a response of some kind in place for 30 odd years. We have a framework which sets out what good practice looks like. We have intelligence gathering capability. We can respond when fraud does happen. And importantly, we can target proactively intervention opportunities. And actually, there's collectively an awful lot of knowledge and expertise in the system. And Nicole is the very embodiment of that. So I think that with the wind and tide in our favour, which I think it is at the moment, then we can continue to improve. And as you say, Janice, what that means is more money for patient care.
Okay, thank you very much, Alex. Some interesting points there for us to look at later on. So I'll just remind you, I've had a couple of questions in already. More questions will be welcome, so continue to submit those in to me. And in the meantime, we'll see what Louis's got to say. Louis, can we have your opening statement, please?
Sure. From our standpoint, what has always been important to us at NHCAA and in the fraud arena, healthcare fraud arena in the US, has been private-public partnership. Because of the way healthcare is paid for in the United States, you have Medicare and Medicaid, which are Medicare is a federal program for the elderly. Medicaid is funded both federally and by the states for folks below a certain income level. And then you have private insurance, a big portion of which is usually paid by employers, with employees paying a percentage of that. Because of that mix of payers, it's always been critical from our standpoint to bring all of the payers together, both on the private and public side. So we work closely not only with the health insurance companies, but with the FBI, the Department of Justice, the Inspector General's Office at the Department of Health and Human Services, the Centers for Medicare and Medicaid Services, bring all of those players together with the health insurers and do what we believe is a critical thing, that is sharing information. Because when you're trying to figure out what kind of fraud is out there, you can't do it in a silo, only with respect to the claims that you're paying. You have to get the bigger picture. So the big thing, the whole concept behind our organization was to bring those payers together and share information. The other two big issues, I think, from our standpoint are, as we go forward, is obviously data analytics. Critically important to trying to figure out what kind of fraud is out there, what the schemes are. It's becoming more and more critically important as we go forward. And we're seeing that both on the federal side and the state and the private side. I think you can't do this work unless you're really on the cutting edge now of data analytics. The concept being to prevent the fraud before it happens, to catch it as early as possible, and not be in a pay and chase situation where you pay out and then you go back and try to collect. And then the other big issue, in addition to sharing information and data analytics, I believe, is resources. What kind of resources are you going to put into anti-fraud work? In this country, in the United States, we spend over $4 trillion now on healthcare. almost 20% of the gross national product is healthcare. So when you look at those numbers, I think you have to ask yourself whether you're the government or a health insurance company, what kind of resources you go and putting into anti-fraud work. Just to give you a sense of how much fraud there is in the system, the Journal of the American Medical Association, JAMA, back in 2019 did a study, and they found that there's between just in Medicare alone, and this is the program for the elderly, between $55 billion and $83 billion in fraud. So it's an enormous problem. And so the question is, what kind of resources are you going to put into it from the standpoint of data analytics, investigators, all of that is incredibly important.
Okay, thank you, Louis. It's very interesting, certainly, to hear how the issues, some similar, some not so similar with the US are to the UK and other countries. Right, please continue to enter your questions to me. I've got a few more in now, but continue with that and we'll get through as many as we can afterwards. Meantime, we'll go over to Nicole. Nicole, can we have your opening statement, please?
Yeah, thank you. So I think within the NHS, the main challenges, as very similar to what Louis just said, are about resources, both financial and the challenges of recruiting and retaining staff. We offer so many types of healthcare to an increasing population with ever more complex health needs, alongside huge advances in medical treatment available, and pretty much all of that is funded by the government via taxes. Staff are simultaneously feeling underappreciated, overworked. They're being attracted to the private sector to improve their lifestyle, both financially and from a work-life balance, as evidenced by the recent industrial action being taken across England and Wales. The private sector see huge opportunities to both help the NHS, but also to make a profit for themselves. A lot of what they offer could be valuable and helpful, but often is badly thought out. There's a lack of engagement and an understanding of exactly what is needed and how complicated the NHS is. I mean, I've worked in the NHS for about 20 years. It is way more complicated than many people give it credit for, potentially way more complicated than it actually needs to be. But that's the way it is. It's a complicated organisation with numerous functions. The private sector sometimes come in with short-term solutions, and they're not necessarily the answer. They see it as a quick fix, a quick money-making venture. The type of involvement offered by the private sector is often focused on digital solutions, data analytics, etc. All good, all great, although sometimes it's not what we predominantly need. The NHS is a people-focused organisation. We treat people, people are treated by people, and they all need to have the appropriate qualifications. And so sometimes the data and the bureaucracy is second to the priority, which is obviously helping people get better. I think the key challenge for the private sector, there needs to be more of a long-term planning, maybe slightly more innovative, use more initiatives, maybe consider it as more of a charitable involvement. It's very difficult, I think, to make money out of the NHS because resources are so limited, and we're constantly being asked to make cuts, to make budget cuts. If the private sector work with this more as seeing it as some kind of social engagement, a social responsibility, then that might be one of the way forwards that could be considered. Focusing on fraud. There's a reluctance by some private sector organisations to work with the NHS investigating fraud. There's really not enough money for them to make it worth their while. There's also reluctance within the NHS to pay people to investigate fraud when they've already lost potentially a very significant amount of money already. So that's a real challenge for both sectors to have a professional investigation service and to be able to fund that service as well. I think sometimes the private sector are able to offer so much more than maybe the public sector in terms of innovation, technical ability, software, etc. But we just really need to understand how we can use that and how we can afford to use that.
Okay, thank you. And so just to remind you to continue to submit your questions. We've got quite a few now. I'd like to thank the panel for their opening statements. So we'll now open the floor really and look at a few questions that we've had in. First question I'm going to ask, I'm going to put this to you first, Alex, and then to you, Louis. We've had a question in from Ewan Grant. basically saying, do you see any sort of correlation between fraud and between sort of malpractice, serious medical malpractice? Do you think there's any evidence of this?
I think it's a really interesting question. I mean, the short answer is I don't think we've actually done any form of study to link the two. Arguably, everything that we do in terms of suppressing loss in the system ultimately links back to patient safety, because it's about putting money back into the system where it can be used to treat patients. Probably a more direct example would be, for example, we've recently seen an individual convicted of having fake medical qualifications, a doctor that had been practicing for many years in the National Health Service, who'd originally practiced overseas and had forged certification. Now, I think that's a clear link to patient safety. Actually, what we found, or what's been subsequently found, is there's been an in-depth examination of overseas medical certificates, and there have been no further cases identified. Quite a substantial piece of work. And of course, in other areas like the issuing of prescriptions and controlled drugs, in particular, we've issued comprehensive guidance on how that is linked to patient safety, but I don't think we've actually sort of married up the two. I can think of some examples of cases, recent very sad cases, where consultants have been found, I think guilty is the right word, of having committed medical malpractice, for example, in the surgery space. I don't think we'd routinely consider that to be a fraud issue, but it does raise some interesting points about governance and management in general of the way that services are delivered, and perhaps that's something we should look into a bit more detail.
Thank you. Yeah, I think it's quite an interesting area. Quite often you might actually find that the two go hand in hand, but whether there is any direct correlation in which sort of comes before the other, I'm not quite sure on that. It's very easy to look back and see these correlations, but probably not quite so easy at the time when you find one to actually think about, the other. Louis, do you have any comments on that malpractice, serious malpractice, and the link with fraud?
Yeah, I think I'll mention one study that was done, but one of the big issues for us is, you often find that healthcare fraud does result in patient harm. We've had cases in this country of providers providing unnecessary services just for the purpose of billing for those services. So you could have patients being treated for things that they don't need to be treated for, tested for things they don't need to be tested for. A blood test may sound like not a big deal, but if it wasn't a necessary test and you were just ordering it, or the lab was doing it simply to bill for it, okay, somebody stuck a needle in your arm and took blood for absolutely no reason. Opioid, same thing. There have been so many cases in this country where physicians were just basically running pill mills, where they were basically writing prescriptions for opioids. We do sense and see that usually providers that commit healthcare fraud are not going to be your best providers. Now, recently, Johns Hopkins Bloomberg School of Public Health did a study, and they found that for physicians that had been excluded from the Medicare program, in other words, they had some problems with fraud and they were excluded from participating in the program, there was a 14 to 17% more likelihood of death for their patients than it was for other patients. So I think anybody, if you have a healthcare provider that's committing fraud, odds are that's not the healthcare provider that you want to go to get your medical care from.
Okay, thank you, Louis. Just see what other questions we've got now. Can just remind you to continue to submit your questions, and we'll try and get through them. One question I've got, and this is probably more likely for you, Louis, just a very quick question. You ever handled any insurance card fraud, that as well as a sort of healthcare fraud?
Oh, insurance card where there's sort of identity theft for us.
Yes.
Yeah, I mean, that does happen, but it's not. It's not when you look at dollars and that kind of thing, it's kind of a much smaller percentage of fraud. You know, the big ticket items are provider fraud, but it certainly does happen where you do have identity theft, where you know, somebody's using somebody's Medicare card or private health insurance card. Medicare does keep track of. They know that there have been a number of Medicare numbers that have been compromised. So they do try to keep track of that. And so it's certainly an issue, but from a certainly from a dollar standpoint, it's not the biggest issue. But certainly if your identity has been compromised in that way, it's certainly a big issue for you if that happens.
It's a Nicole, I think, is there any particular area at the moment that you're spotting on the ground that's increasing or decreasing? What's giving you particular concern at the moment within the hospitals that you deal with?
I'd say our top 2 frauds of the moment, if we're going to have a top 10, are probably working whilst I'm sick. So staff either working elsewhere and submitting a fit note saying they're too sick to work, then working elsewhere. And I'd say, secondly, the biggest issue for us is mandate frauds arising from phishing emails. So we're being asked to change bank account details, and then it turns out that the supplier email has been hacked, and then the payment's been made into a rogue bank account. So I'd say there are 2 biggest frauds at the moment, and those are not unique to our organisations. I know that they are risks across the entire sector.
Indeed, not only to your organisation, but not only to the healthcare sector either, but to other sectors as well, public sector and private sector. I want to move on to speak a little bit more before we finish the session today, because we said as one of the topics is how can the public and private sector sort of learn from each other and work better together to tackle fraud. And I'm quite interested with the fact that, and obviously Louis opened up saying that because of the nature of how the healthcare system works within the US, obviously you have to work very closely with the private sector and with state and federal bodies as well. But I was wanted to also raise the issue before we go on to that, really, with Alex, in terms of, and perhaps Alex will be able to explain this a little bit better for those of you who are not familiar with this, but in the way with the NHS in the UK, we have a sort of public and private element as well within healthcare within the UK, but also within the NHS, we have this difficulty of what we call contractors. And what I mean by that is, you know, the GPs, I see Alex already smiling, the GPs, the pharmacists, the dentists, the opticians, etc. But although they work for the NHS or work for them in part, they're not actually employed by the NHS. I suppose before we examine this sort of public and private issue, we've got these sitting sort of in the middle. So I was just interested to hear off Alex and Nicole if she's got any comments as well. What, whether this actually helps or actually goes against helping investigate fraud within the UK.
Yeah, well, that's an interesting question. Yeah, and I think somebody asked a question in the panel, in the Q&A panel about 25,000 employees of what Nicole described as a huge trust. But I think that's kind of the point, because actually, although I think there are 1.7 million people employed by the NHS, community doctors, pharmacists, etc., opticians, dentists are not directly employed by the NHS. Effectively, they operate franchises that are contracted by the NHS to deliver services. A lot of that's a legacy of the service when it was set up 75 years ago, and the negotiations that were taking place. It's not a plug or anything, but I heard somebody talk the other day on the radio about a book that was written in the 1930s called the Citadel, which was described how healthcare was delivered in England before, in fact in Wales actually, in the UK, before the health service was started. And it describes many of the challenges that existed without having a national health service in place to drive strategy and to drive national improvement. So it might be worth some listeners having a look at that book. You're right though, Janice, it is very difficult to have a shared strategy and a shared sense of risk when you're managing quite a diverse group of professionals operating in what was a scenario that's not dissimilar to a private sector environment. There are benefits of that as well, and part of it's by design, because although we describe it as a national health service, one of the things that's been identified over many years is the need for local people and local services to deliver the type of services that are relevant and necessary for that area that it's operating in, and that's part of the ethos of the NHS. So to an extent, I think we've got to kind of work with that. But for me, it's about relationships with professional bodies and the organisations that provide that support. And actually, I would say throughout the NHS, there are public-private sector partnerships happening on a daily basis, just to deliver daily service delivery. And that's right from all the equipment that's used, the analysis that takes place. You may have seen a lot in the press recently about AI, machine learning. That's already being used to improve patient care. Much of that is developed in the private sector. It's not necessarily delivered by public sector organisations. So there are when we talk about construction and procurement as well, there is a big health industry. It's already operating in a public-private partnership, I would argue.
Because of these sort of quasi sort of public sector, private sector sort of contractors, though, do you have an issue, Nicole, this might be something you want to respond to, do you have an issue when you're actually investigating fraud of actually how far you can go in terms of looking at their records or whatever? Because obviously there's public records and there's their own private practice records. Does that cause an issue?
It obviously poses challenges. I think the main risk associated with the contractors is that they're paid by claims, the number of claims. So there is an incentive, obviously, to inflate the amount of work they are actually doing in order to get more money. The more work you do, the more money you get paid. However, we do have specific legislation available to us, which allows us to access patient records from contractors. The Counter Fraud Authority has some fairly far-reaching powers under the Health Service Act. That means we can access that. Any work they do is also regulated by their own body, like the NMC, the GMC, etc. So we're able to sometimes work in close collaboration with them. But in terms of their private practice, it does definitely fall outside of our scope. And in terms of actual practicalities, if they're doing it privately, it's not really something that we would think about. We're only concerned about money being taken away from the NHS. So that's probably a weakness there.
Yeah. Okay, and I just want to move on to Louis now, to bring him into this sort of public-private discussion, because obviously we'd be interested to hear how working with the sort of private sector and the public sector sort of works for you. And if there's obviously you've they're both part of your organisation, you've obviously worked successfully for a number of years, and it would be interesting certainly for us in the UK, for Alex and Nicole, to hear about if there's anything we can learn from that kind of partnership arrangement in the US, Louis.
Yeah, from the beginning, our partnership was again sort of a voluntary type of partnership. In other words, it's not in any way mandated, but all of the payers saw the benefit of coming together. So, for example, on my board of directors, I have a number of folks that represent health insurance companies. But then I also, again, have representatives from the Department of Justice, FBI, HHS, OIG, some other entities. And what they recognize is that if providers are committing fraud against the private payers, they're also doing the same thing against the public payers. Public payers, to the extent that they're doing it against the public payers, they're also doing it to the private payers. So in order to be as effective as you could possibly be, those payers have to share, what are the schemes? What are the new schemes that are happening? What are you seeing? And then because of the size of our country, what are you seeing in certain geographic areas? Something that may start in South Florida will wind up in Southern California or in Detroit. The schemes basically evolve and travel across the country. So the earlier you know about it, the earlier you're going to be able to be looking for those types of things. So it's been really, really important. Another initiative that started in this country a few years ago is something that the federal government is funding called the Healthcare Fraud Prevention Partnership, where they're actually taking claims data, private insurance company claims data, Medicare data, Medicaid data, actual claims data, aggregating all of that claims data, and then doing specific studies, data analytics on that claims data to try to, again, the concept of getting ahead of the curve, trying to prevent things before they happen or finding out about them as early as possible. And again, there you have the federal government, state governments, and the private side coming together to share claims data, to do data analytics on that. So I think in this country, we've recognized to be successful against healthcare fraud, you have to bring those payers together. You have to share information. You have to coordinate as much as you can. Even though, in this country, the private side contracts with the government as well. There is a good number of Medicare enrollees now, almost 50%, that are enrolled in private health plans, and the government is paying those premiums. And even in Medicaid, there's Medicaid managed care plans that the states are paying to run, basically provide the benefits. So there's that close relationship too between the government and the private side from a contracting standpoint. So it's in everybody's interest to really come together and try to work as closely as possible to really, if you're going to be successful, you just have to do that.
Okay, thanks, Louis. Just so finally, before we start to wrap up, the last topic I want to look at really is sort of, the future of medicine and how this might affect fraud. Now, obviously, I think in the US, we've already got quite a lot of this, but I think we're seeing now more and more online kind of telemedicine, prescriptions, etc. And I just wondered, first of all, Alex, if you could say, has the sort of online prescribing had any sort of impact on fraud, do you think, so far?
Yeah, I think it's a really good question. So I think we can, as you say, well, let's just look at what's happening in the NHS now. So virtual wards, for example. So we now have patients that would have been sitting in a hospital ward with a whole load of other people now at home wearing monitors, which doctors, medical professionals are monitoring remotely, and will create an intervention opportunity if the data tells us that that's required. Of course, we're perhaps more slowly than others moving towards a fully digitalized system. We're in the process of procuring a federated data platform, which will hold much of our information. So whilst I think you're right, Janice, whilst there are some risks that are created with these scenarios that you describe, actually, I think there's also tremendous opportunities, and those opportunities usually sit in the data space and our ability to analyze data. And I think, talking to Louis previously about the work that's done in the US in identifying outliers and understanding how data can inform your understanding of fraud is going to be really critical for us in the future. And that's definitely the space that we see our organization operating in as we go forward. But I also recognize Nicole's point about the human element, and we can't do everything sitting behind desks. Hospitals are still physical places where people meet each other and undertake real life activity. So I think we're going to have to balance the two elements of that as we carry on, because particularly when we look at sort of staff fraud issues, for example, majority of our staff are in hospitals, coming into work, doing their job, getting on with things. Yeah, I think it's probably just it's both a threat and an opportunity, this sort of digitalization of services.
Yeah, I agree with you totally. You know, there's amazing advances in the healthcare sector using it, but obviously there's potential for using it to counter fraud as well. But also at the end of the day, we've got to remember the human element, and we know a lot of fraud is discovered by tip-offs from staff.
But I think we have to recognise, yeah, I mean, one thing I would say is, I mean, the NHS is actually very good at collecting data, and you know, that's how we know that we're underperforming in some areas because we're good at collecting data. But how do we harness that so that we can make the best use of that to be efficient and save money? So part of the conversations that we're having is about with you know, senior officials is about, yes, there's efficiency in the clinical space, but there's also financial efficiency that we can deliver through better use of technology.
Louis, I just wondered if you've got any comments on the advances in technology and how that's affecting fraud in the US.
Oh, yeah, I mean, it's a big initiative here. The Department of Health and Human Services, because of the results of COVID and loosening up the rules with respect to the provision of services via, you know, electronic means. And now they're basically leaving those rules the way they are post-COVID. The Department of Health and Human Services is really focusing on telehealth and the potential fraud there. We've actually put together a work group, as Alex mentioned, on remote patient monitoring, because that's the big thing coming down the road next. So we have a work group comprising, again, a private side and the public side, taking a look at it and coming up with some recommendations on how to prevent fraud in the future in that particular area. And for example, at our conference coming up later this year, we'll actually have a session on that, on best practices. So it's definitely a big concern, but it's not going away because it's going to be the new wave of the future. So you want to, again, understand it and try to anticipate as much as possible what the potential fraud is that may arise out of that.
Okay, thank you, Louis. And I want to say thank you to all the panel members. Thank you. It's been a really, really interesting discussion. We've only touched the tip of the iceberg, really. I'm sure we're all four very passionate about tackling healthcare fraud. We could probably stay here all afternoon, but unfortunately we have to finish in a minute or two. So I'd like to say thank you once again to the panel and for the questions that you submitted as well. Sorry if we didn't get to all of them. We did have quite a lot of questions in today. Just a few notices before we actually finish the webinar today. Call for nominations for the Benelux, the Tackling Economic Crime Awards, obviously applicable to this group, Southeast Asia OSPAs on security, and Australia OSPAs. We've had a few technical problems with our entry websites this morning, so if you do go to them today and you're having problems, please go back tomorrow and I'm sure we'll have it solved with them then. And in another 2 weeks we'll be doing it all over again. Martin Gill will be chairing the next webinar about tackling sustainability, how common is greenwashing and what can we do about it. Once again then, I'd like to say thank you for to all members of the panel for their insights today. I'd like to thank you, the audience, for being here and listening to us and submitting your questions, and not least to Shrey, our technical guy in the background here, making this all work for us. And as we always say, wherever you are in the world, till we see you next time, please take care.